urinary tract arises from various factors that promote crystallization of minerals and compounds in the urine. Its etiology can be broadly categorized into metabolic, dietary, environmental, anatomic, genetic, and infectious causes. Here's a detailed overview. Etiology of urolithiasis. 1. Metabolic causes. Hypercalciuria, excess calcium in the urine, the most common metabolic abnormality. Causes include primary hyperparathyroidism, renal tubular acidosis, idiopathic hypercalciuria, hyperoxaluria, elevated oxalate levels in the urine due to increased dietary oxalate, e.g. spinach, nuts, enteric hyperoxaluria, e.g. malabsorption syndromes, Crohn's disease, primary hyperoxaluria, genetic defect, hyperuricosuria, high uric acid in urine, seen in gout, high purine diet, e.g. red meat, seafood, myeloproliferative disorders or chemotherapy, hypocitraturia, low citrate levels, reducing inhibition of stone formation caused by renal tubular acidosis, chronic diarrhea, high protein diet, cystinuria, genetic disorder causing excessive cysteine excretion and cystine stones, hyperphosphaturia, increased phosphate excretion, often seen in hyperparathyroidism. 2. Dietary and lifestyle factors. Low fluid intake increases urine concentration and promotes crystal formation. High intake of oxalate-rich foods, spinach, rhubarb, nuts, and tea. Excess animal protein raises urinary calcium and uric acid while lowering urinary citrate. High sodium diet promotes calcium excretion and stone formation. Excessive intake of sugar or fructose linked to increased stone risk. Part 3. Environmental factors. Climate and geography. Hot, arid climates increase dehydration and concentrated urine. Stone belt, regions with high prevalence. Seasonal variation, higher stone formation in summer due to dehydration. 4. Anatomic abnormalities. Urinary stasis, obstruction, e.g. ureteropelvic junction obstruction, strictures, vesicoureteral reflux, neurogenic bladder. Structural anomalies, horseshoe kidney, medullary sponge kidney, polycystic kidney disease. 5. Infectious causes. Struvite stones, infection stones. Formed by urea-splitting bacteria, e.g. Proteus, Klebsiella, Pseudomonas, associated with alkaline urine and chronic urinary tract infections. 6. Genetic factors. Cystinuria, autosomal recessive disorder causing cystine stone formation. Primary hyperoxaluria, rare genetic disorder leading to excessive oxalate production. Familial renal tubular acidosis contributes to calcium phosphate stone formation. Drug-induced urolithiasis. Certain medications can crystallize in urine and form stones, including indinavir, antiretroviral, topiramate, antiepileptic, triamterene, diuretic, sulfa drugs, antibiotics. 8. Systemic disorders, hyperparathyroidism, excess calcium and phosphate excretion. Gout, high uric acid levels leading to uric acid stones. Obesity and metabolic syndrome, increased risk of calcium oxalate and uric acid stones. Diabetes mellitus, associated with acidic urine favoring uric acid stone formation. Pathophysiology. The key process involves 1. Supersaturation. Urine becomes supersaturated with stone-forming solutes, calcium, oxalate, uric acid. 2. Nucleation. Crystals form and aggregate. 3. Retention. Crystals adhere to urothelium or remain in the urinary tract. 4. Growth and aggregation. Stones grow larger due to persistent imbalance in urine composition. Understanding the underlying etiology is crucial for preventing recurrence and tailoring treatment strategies.